So good afternoon, everyone, and welcome to our webinar, 340B discount program. What is it? Does it work? Why is it a policy problem? My name is Robert Popovian. I am a visiting fellow at the Pioneer Institute's Pioneers Life Sciences Initiative. I'm here with Dr. Bill Smith, who is our senior fellow and the director of the Pioneer Life Sciences Initiative. Just to guys give an idea with regards to this project, there are a couple of other people involved. Gary Benoit, who's our research assistant, as well as Michael Walker, who's a senior fellow in Pioneer Analytics. And I believe they're online. Bill and I are here live in DC. So a couple of things for our audience. For those of you that are online, if you have any questions, please put it in the Q&A chat. And Caitlin, who is here with us from the Pioneer Institute, will let me know, and we will answer all those questions at the end of our discussion. For those in the room, obviously you may interrupt us and let us know if you have any thoughts or comments. But let's get started because we have a lot of things to discuss, and I'm gonna turn it over to Bill, who is gonna kick us off. So Bill.
Thank you, Robert. First of all, we are in a glorious office in 101 Constitution Avenue, and it is not the Pioneer office, for the record. We have a modest office in this building, but we have a spectacular, unfortunately for the people on Zoom, we have a spectacular view of the Capitol and the congressional buildings. It's really quite nice. I'm just going to give a few preliminary slides to help explain, and a lot of people on the call may already know this subject matter, but to explain where the program came from, the 340B program, and why it's problematic from a policy perspective. I think it was a very poorly written statute. We actually had a court case within the last week, a federal appeals court case where they told HRSA, the HHS agency which manages the 340B program, that since there's no statutory definition of an eligible patient within the program, within the statute, therefore HRSA couldn't audit whether covered entities, hospitals and clinics, were actually serving the patients that were intended to be served. So that's how poorly written the statute is. I'm not saying the court decision was wrongly decided. I just think this is a program that's very ripe for reform. So where did it come from? Well, in 1990, the Congress, in its wisdom, decided that the Medicaid program should get the best price of any payer in the United States. It's called the best price law, Medicaid rebate law. And this turned out to be a problem for some hospitals and clinics because pharma manufacturers at the time were giving voluntary discounts to many hospitals that treated lots of low-income patients. And so this was problematic because suddenly that became the best price. These voluntary discounts became the best price for manufacturers. And the hospitals were very concerned that their discounts were going to go away. So Congress stepped in 1992, they created the 340B program. It required manufacturers to give deep discounts to hospitals and clinics serving low-income patients. And it exempted these prices under the 340B program from the OBRA 90, the best price law passed in 1990. And facilities became eligible generally. There are a few ways you can become a 340B covered entity, but the primary way is if you serve 11.75% Medicaid in your facility, then you become eligible for 340B. The Congress felt that 11.75% Medicaid patient population was a good proxy for a hospital or clinic that might be treating low-income populations. So that's where the program came from. Let's go to the next slide. Well, how does it work? Well, here are a couple of examples of how a hospital could arbitrage the discounts that they get under 340B. So a Medicare patient comes in, they unfortunately get a cancer diagnosis, and they require an expensive cancer medication that has a list price of about $100,000. But the hospital can purchase that medication for $25,000. So they dispense the drug to the Medicare patient. They've paid $25,000 for it. but then they bill Medicare at the standard Medicare reimbursement rate, which is 106% of average sales price, or about $95,000. The hospital's profit margin on that one prescription is $70,000 for a Medicare patient. The same problem exists with commercial insurance. Hospitals can purchase oncology drugs at a discounted price and then bill the health plan at their list price or their negotiated rate, and they make substantial profits. The hospitals don't make substantial profits when they give these medications, these discounted medications, to an uninsured patient because they get no reimbursement. So the incentives in the program are designed to bring in people who have very strong insurance coverage, not necessarily to bring in people who are uninsured or low income or are paying a lot out of pocket. So that's the incentive structure of the program. And we've seen that this create problems. Next slide, please. So why is it a policy problem? Well, as I just said, there's an incentive to arbitrage the discounts with insured populations. One study in 2019 said that there were 40 billion in revenue coming into covered entities under this program. Our guess is it's well over 50 billion by now. The program has, for obvious reasons, has had uncontrolled growth. In 2022, hospitals and clinics and covered entities purchased $53 billion worth of drugs at discounted prices. At list prices, those drugs would have cost $106 billion. So by 2026, it's projected that this will be the largest federal drug program, surpassing Medicare. So when the program first started, there were a small number of hospitals and clinics. It was in the low hundreds, but growth came because the Affordable Care Act expanded Medicaid dramatically. And so what that meant is that where there are many more Medicaid patients coming into hospitals, which means many more hospitals and clinics were achieving that 11.75% threshold. So the number of covered entities has exploded from about 550 in the 1990s to 10,000. Another problematic aspect of the program is that hospitals and covered entities in particular have discovered that they can go into wealthy suburbs and buy up community-based physician practices, particularly those practices that prescribe high-cost drugs, oncology, neurology, and others. And there have been takeovers of many of these physician practices, and they're serving wealthier patients that have good insurance for the reasons I explained. And for-profit PBMs and pharmacies are now dominating the program. There are 32,000 pharmacies. Robert is actually going to update that number. I think that number is about a year old. There are 32,000 pharmacies participating in the program at about a year ago, and 75% of them are for-profits: CVS, Walgreens, Express Scripts, Optum, and Walmart. Now, the most troubling aspect of this program, and I think one of the reasons at Pioneer we decided to dive into it, is that as this program exploded and revenue was coming into many of these covered entities in the billions of dollars, at that same time that was happening, these covered entities in hospitals and clinics were giving out less and less charity care. Now, that's not the case with every individual hospital or clinic. There are some that are still spending a good deal of money on charity care, but as a general trend, and you can see it on our web tool, which Robert will explain, the trends are way down for charity care spending, and uncompensated care is at kind of lows. So part of that is due to the Medicaid expansions, but there are still 45 million people that are uninsured, and charity care provision is declining. Next slide, please. So here's a slide that shows the growth since 2015 in the program. As you see, as I mentioned it, in 2022, 53 billion in purchases at discounted prices, 106 billion at list prices. The growth in this program is unquestioned, and it's substantial, and it's double digits every year. Next slide, please. And here's, again, this is what the most troubling aspect to me. At the same time, this program growth, in which you can see the program growth from 2012 to 2022, in that decade, charity care declined from 3.6% of covered entities or DSH hospitals revenue to 2.5%. At the same time, a huge revenue windfall was happening because of the 340B program. This is in my mind, the most troubling slide about the program. And there's more. Again, you can dive into the numbers with our tool and look at individual hospitals and what their rates of charity care provision are. But 69% of 340B DSH hospitals provide charity care rate at rates lower than the national average of hospitals. And there are some data to suggest for-profit hospitals are giving more charity care than nonprofit hospitals. 36% of 340B DSH hospitals provide charity care that represents less than 1% of their total operating costs. And again, we live in a country where there's 49% that do not have insurance. And 25% of 340B DSH hospitals account for 80% of the charity care provided in 340B hospitals. There are, as I said, a smaller number, but there are good actors in this space. There are some hospitals I've seen in Massachusetts that are giving double digits as far as their revenues in charity care. But then there are other wealthy hospitals who will go unnamed that are giving less than 1%. So it's a very uneven picture, but generally the charity care rates are down. And non-340B short-term acute care hospitals have equal charity care to 340B DSH hospitals. So a 340B hospital is getting a tax break for being a nonprofit. It's getting revenue from a 340B program. It has substantial financial benefits associated with its status, and yet non-340B hospitals are matching them as far as charity care is concerned. So with that foundational explanation, I'll turn it over to Robert, and he'll show you the tool that we've developed, which can help you flesh out some of the conclusions that I've reached.
All right, so thank you, Bill. And just to remind everyone, if you have any questions here in the room, please interrupt us. And if for those that are on the phone on our Zoom call, please put it on the Q&A, and Caitlin will get it to us and let us know at the end, and we will answer all the questions. So the 340B contract pharmacy project, why did we do this? You know, one of the things that happened, and Bill mentioned this, after the Affordable Care Act passed, you know, there was a cap, the cap on number of contract pharmacies went away. And what we've seen since the 2010, there's been a significant growth in number of pharmacies. And what we wanted to do is do a micro level assessment of where these pharmacies are located. And the reason we got interested in this is because of an article that was published last year that really showed this was that the pharmacies that are supposedly serving poor patients are not necessarily located in poor communities. And we wanted to see if that's true. And plus, we added some other things to it with regards to geomapping, with regards to House and Senate districts on the state level, as well as then looking at the charitable care. So let's go to the next slide. So when you go to the Pioneer website, there's a link that you can go, and it's open to anyone who's interested in looking at this data in more detail. It's called 340B Abuse. And initially, when we launched the program late last year, Bill and I, we only had the left side, which is the 340B area. The legislative mapping and the hospital charity care information is new, and it's from publicly available information. The hospital charity care data actually it's a proprietary database that we acquired from Rand Institute to be able to put it in here. So it's not, it's something Rand has done for many, many years of following different hospitals and looking at their charity care level.
Yeah, we purchased the Rand data, not to interrupt, because the reporting of charity care by hospitals is uneven. A lot of them use different standards to report different things. Rand tried to comb through that data and sort out the unevenness and make it more uniform. So we went ahead and purchased the data because we think it's the most reliable out there.
Absolutely. Let's go to the next slide. So this is from the original website that we developed. So, and you will see a lot of examples in California and New York and Massachusetts. The reason being is that I used to live in California. Bill worked in Massachusetts, and frankly, New York is a large state. So in this case, we're looking at California. If you look at the left side, it tells you all the covered entities and number of contract pharmacies for each covered entity. And then what you can do is that look at specifically whether you want to look at a dish hospital or you want to look at a clinic, and then see how many contract pharmacies are for that institution. And you can do it per institution also, and I'll show you later, but you can do it on the state level and in each state, and we have covered all 50 states plus District of Columbia. Next slide. So this is, let's go back one more time. I want to show you one more thing actually. So then if you click on the individual institution, you can see it. And you can see how many hospital contract pharmacies they have. Then let's go to the next slide. So Bill mentioned that the growth in contract pharmacies has been expanding since ACA passage, and that's because of the cap was removed. And you clearly see, there's like now over 38,000 pharmacies participating. I think there's been some reduction, Bill, in the last 12 months because of the court ruling that came sort of required some of these contract pharmacies to provide information back to the manufacturers. But you see the number of contracts, the number of covered entities have exploded over time. Partially, this has to do with the covered entities because of the Medicaid expansion, without a doubt. And the removal of the cap on the pharmacy side has exploded. And we'll go through more in detail about who are these pharmacies and where they're located. Let's go to the next slide. So one of the things you can do in the tool, for example, you can go and look at individual states and look at whether or not a state has, how many pharmacies, contract pharmacies they have within the state, and how many of those institutions, the covered entities, have contracts with pharmacies out of the state. So what you could see is that state of California, number of contract pharmacies that are working with the covered entities, and number of contract pharmacies out of the state of California that have affiliations with covered entities within the state of California. And then you can look at individual institutions. Like, for example, the number one institution in California is University of California, Davis. And then you can look at number of contract pharmacies that UC Davis has sort of partnered with and contracts with. And then the contract pharmacies exist beyond the state lines outside California for University of California, Davis. You'll notice they have contract pharmacies all the way in upper Northeast, in Florida, in Texas, in Washington State. And this is one of the trends you will see, is that about 30% of contract pharmacies that are affiliated with these institutions are outside the state lines. And there's no good explanation of why. And this also sort of goes in parallel to the research that's been previously done. And we'll get into more details about the questioning of why do you need to have so many contract pharmacies outside the state lines, especially a state like California. So one of the things that we did with this newer data that we have now, we looked at number of contracts. What pharmacies have the most contracts existing as of when I pulled the data about 2 weeks ago? And, out of the top 12, what you see, first of all, they're all for-profit institutions. The number 1 and 2 is Walmart, with regards to the number of contracts. But then the next 10 are specialty pharmacies that are owned by pharmacy benefit management companies. So this is big business. This is not about your mom and pop pharmacy, the community pharmacy that is working with the local covered entity institution that's providing care for the poor in that community. This is big business. It's primarily being run, the first 2 are Walmart, but everything else is PBM owned. And that's another way of looking at how vertical integration in the healthcare system, whether it's the insurers and the PBMs, has gotten into this business of 340B now. So when there was a time, when Bill and I were both in industry, that PBMs and insurers were really the gatekeepers for this program, right? There were institutions that didn't want to see the expansion and abuse because they were paying for this stuff. Now with vertical integration, they're the same. Everybody's making money off of it. So you see this thing where the PBMs have become a big player in the 340B space. Next. Yes.
Thank you so much. This is fantastic. And I could spend a year looking through all this stuff.
Yeah.
I'm not sure I understand the business model that's going on here. Why do we need a whole bunch of contract pharmacies? If I'm UC Davis and I want to turn 340B into a profit center, why do I have to have contracts with a bunch of different contract pharmacies instead of just straight with?
That's one of the questions that commonly comes up. is that why do you need a contract pharmacy all the way in Maine, for example, or Florida if you're in a California institution? Now, when I've been on panels, some smaller states, it makes sense. Like if you're in New York, Connecticut, New Jersey, geography wise, you may have patients that live within the state borders. It makes sense to have it. Same thing in like where I live in Virginia, right here, Virginia, DC, and Maryland. But it doesn't make sense why you have it in all the way in California or Hawaii or Puerto Rico. It just doesn't. And the excuse is, well, these are mail order pharmacies. Well, if they're mail order pharmacies, first of all, these institutions should be serving the community that they're the covered entity. And the second thing, especially in a state like California, you can't argue that there aren't enough mail order pharmacies in the state of California to serve the California patient population. And you have to go all the way to Florida to do it. So when you ask covered entities and the pharmacies, Bill and I have this conversation with their CEOs, everybody points to the other person as being the problem. The pharmacies say, well, you know, the covered entity is the one that comes and wants to contract with us. And then when you talk to the pharmacy, they say it's and then when you talk to the covered entity, it's the pharmacy that pursues them for a contract. So nobody knows why is this expansion happen other than it's a bunch of for-profit pharmacies that are making a lot of money.
It seems to me, as Dr. Smith was describing, you know, the growth in the 90s, it looks to me like a small number of consultants figured out how to turn 340B into a profit.
Absolutely.
And they go around and visit hospitals and health systems and say, here's how to do it.
I think this is the classic story of a federal program that was taken over by the vendors, right?
Yeah.
And it's lost its original mission. It's taken over by the vendors.
And it's a great program and it should be preserved. I actually practiced in an institution that significantly benefits from 340B program. It's the LA County Hospital. And that institution actually, if you look at the number of contract pharmacies, they only have 4 contract pharmacies. So they actually are meeting the mission of their institution that they're only contracting with pharmacies right in their geography. It's the ones that UC Davis or UCLA that are all over the map, and you can't explain why.
And if you look at the reimbursement structure for a contract pharmacy, the 340B program is a very lucrative program. So there's every incentive for them to sign a contract with a covered entity.
So then this is a newer data that we came up for the website is the geo mapping of district mapping, base mapping. So this is New York State. You can look at each assembly and Senate district and see number of contract pharmacies and also number of hospitals and number of clinics in that district for that representative district or the Senate district. In this case, it's the assembly basically that we're looking at. And the reason we did this is because, again, remember, we started the whole program because we were interested, where are these pharmacies located? Because remember, the JAMA article was very clear, they're not located in poor neighborhoods. So we did this, so anybody can go in and look at their assembly district, see how many contract pharmacies are there, and number of hospitals or institutions and number of clinics. Next slide. And then I basically picked out House Assembly District 148, and you see number of current centers, hospitals, number of clinics, and number of pharmacies. And if you go to the next slide, you can actually see what these 17 pharmacies are. Who are they? You know, are they the local community pharmacy? Is it Walgreens? Is it CVS? Is it the specialty pharmacy? And they have addresses and everything else. And you can also look at who the hospitals are and who the clinics are in that district. Go to the next slide. And okay, any questions on the hospital pharmacy contractual agreements
and just for the record, we considered doing it by congressional district. When we did that, it was too big. It didn't give meaningful data. You know, you couldn't, with state assembly districts, you can go into a very specific area that might be lower income or wealthier, and you can see whether that area is underserved or overserved by this program. And with congressional districts, the data wasn't meaningful.
Because we did look at Nevada specifically. There are 4 congressional districts in Nevada, and each one of them is so broad that they have the poor neighborhoods like in Las Vegas, and they have the rich neighborhoods in Las Vegas all in one district. It didn't make any sense. So this is a better depiction. So then we go into the charity care data. Frankly, charity care data you see this trend line in every state, which is a drop off after Medicaid expansion. Without a doubt, nationally, we saw charity care drop off after Medicaid expansion. Makes sense. More patients have insurance. Hospitals were not giving as much charity care. You can look at individual state level charity care data. Like, for example, Texas provides the most charity care, it's about 9.49. Then it's Georgia, New Jersey, Florida, Oklahoma, North Carolina, Tennessee. You can look at state level. And then you go to the next slide. You can look at specifically within the state for each institution, what their charity care data is. So for example, this is again, New York, Bellevue, you see Bellevue is doing pretty good compared to average state, which is about 2%. Bellevue is actually doing about 13% charity care based on their revenue, which is good. This is what the trend line you want to see, but this is not the norm in every state. And what you see is what Bill mentioned. Certain hospitals are doing a great job. They're meeting their requirements above and beyond national and state level data, but some institutions are just not doing enough. You go to the next data. Yeah.
Still on that one.
Go back. Okay.
Is this any level of data that's not publicly available, number one, or is it universally available, or is this new data that you have acquired? And number two, how reliable do you think this is as far as their actual charity care performance?
So this is why, I mean, what Bill said, we were going to use the publicly available data first, which is, I think, in HRSA, right?
Yes.
Or Medicaid, CMS collects that data for the hospitals, right?
Yep.
CMS collects that data, and we were initially going to use it. We didn't trust it. We didn't think that the reporting was good enough. So that's why we went and found the RAND.
Correct.
Yeah.
And RAND has been doing this for decades, looking at charity care for hospitals. And we went and acquired the data from RAND because we felt more comfortable that number one, it's normalized. They do a lot of cleanup. And secondly, they've been doing it for a long time. So they have the same standards applied for year over year. So you don't have different standards. And this charity care data is something we acquired from them. So it's not available publicly, but anybody can go to RAND and find the data too.
So that's, I think, what you're talking about when I came in. So this
That's
is
right.
your newly acquired data. So it makes those
That's right.
systems even more reliable.
Exactly. This is probably as reliable as you can get with regards to charity care data for hospitals. I don't necessarily trust the CMS data because who knows what they're reporting and there's no standards and everything else. So at least RAND does clean up.
If someone comes into a hospital and they earn $100,000 a year and they don't pay their MRI bill, is that charity care? Some hospitals say yes, some hospitals say no. So,
Yeah.
you know, it needs to be cleaned up. Congress should step in and make a uniform definition of what it is so we'd know. But I think the RAND data is as reliable as you're gonna get.
That's the thing. It's consistent because they use the same standards year over year. So one of the things that we did based on the assembly level, this is assembly data for, I looked at 6 states. So Massachusetts, Louisiana, Virginia, Illinois, California, and New York. And I said, okay, let's look at where these pharmacies are located within the state. And I looked at the average population living in poverty. And I said, let's look at pharmacies above the poverty rate and below the poverty rate in each state of these 6 states. I only looked at. And you see that, look, Massachusetts and New York are bad. They're just the wealthier versus, you know, Illinois and Virginia are actually pretty good. It's evenly distributed between poor and rich neighborhoods. And this is based on, again, the geomapping tool that we have. And we married it to the data that we see census puts out. So I would say, again, what Bill was saying is true. Some states are doing a pretty good job. Some hospitals, just like some hospitals, are a pretty good job about distribution of these pharmacies, locations with regards to poor and rich districts. And some states like New York and Louisiana and Massachusetts and California are not doing as good of a job. You know, so that's why I think if we create better transparency and better regulations of this program, it's a program that's worthwhile and needs to be safe. But because of this lack of standardization, it's all over the map. and everybody's doing their own thing. And some states are doing it, some hospitals are doing a good job, some states are doing a good job, but not necessarily everybody. So
Yeah.
that's one of the things.
And when I first started working on this program last year, I thought reform might come from the Republican side of the aisle, and I'm not making partisan comments, but I did get a lot of interest from Republican staff in the House, and I got invited by Speaker McCarthy's office to come brief staff counsel from some of the committees about my findings, and I thought, oh, well, Republicans might take up this issue for reform, but the more I get into the data, the more I think people on the left side of the aisle should be concerned about this program, because there are very, very underserved areas that this program is not helping. And it's particularly with that district by state district tool, you can go in and you can, I went in just for fun and I looked at the assembly district in California for Pacific Palisades and Malibu. And I contrasted that with the assembly district for South Central LA. And I found that Malibu and Pacific Palisades had more pharmacies than South Central. I mean, there's things in this tool that make you say this program is not working the way it was intended, and that everybody in a bipartisan fashion should be concerned about reform.
So Bill, before we end, I want you to talk a little bit about the court ruling that we talked about yesterday, and the new court ruling that came out. You want to talk about it?
Yeah, no, we've said from the beginning, and you'll see it in this paper that I did last year, that the statute that created this program was just poorly written. The definitions of who's eligible and who's not, that were not very specific. That's why these discounts can be arbitraged and wealthier patients can be given 340B drugs. The statute needs to be tightened up. But this recent court case within the last couple of days should tell you that this is the very poorly written statute. So HRSA, the HHS agency that runs 340B, would audit covered entities, hospitals and clinics, to see if they were providing drugs to eligible patients. And an eligible patient, HRSA's definition of an eligible patient was a patient treated at a 340B facility. Well, there's nothing in the statute that says the patient has to be treated at a 340B facility. So HRSA was sued by one of these covered entities, I think it was a clinic, and said, we can give these drugs to anybody. If they've just gotten an x-ray in our clinic, they're not really being treated at our clinic, but they came in for an x-ray, they're suddenly an eligible patient. And the court ruled in favor of the covered entity. They said there's no statutory definition to who is an eligible patient. And that just, in my mind, shows how poorly written this statute is. And there's so many other examples of where the program has grown out of control because the statute was not tightly written.
I mean, most recently, we saw the Penn hospital system.
Yeah, there was some litigation that went to the Supreme Court, and Medicare had to reimburse some hospitals who were arguing that they were gypped out of 340B revenue. And in some of the court filings, it came out that Penn Medicine, which is a huge hospital group in Philadelphia, Penn Medicine had, because of their filings, we discovered that they had secured $717 million in 340B revenue for the year ending June 30th. And for that same year, they had given out $38 million in charity care. So, if you can get, we actually FOIA'd the top 10 340B hospitals, and we asked HRSA, what is their revenue? HRSA wouldn't give it to us.
That's the thing. I mean, the lack of transparency in this system is really bad, and it's being taken advantage of to the detriment of patients. And the best part about the tool is that it's sort of like confirms what's been published so far, which is, one, the pharmacies are not located in the poor neighborhoods. Number two, there's lack of transparency of why so many contracts and why do you need so many contracts and why do you need so many pharmacies. And then the last thing is just charity care stuff, which is not consistent with revenue growth in the hospital.
Yeah, and if someone asked me, well, what legislative reform would you start with? And my answer would not be to cut back the 340B program, because I know there are hospitals that they're getting terrible Medicaid reimbursements, they're struggling financially, and we don't want those hospitals, particularly in the communities they're in, to go under. So I wouldn't recommend cutting the program right away. What I would recommend is some transparency, okay? What's your charity care under uniform definition? How much have been given out? How much are you making individually from this program? And let's start there. Then I think you would discover who the good actors and who maybe is not, or not living up to the mission of the program.
And then the other thing is that the whole New York Times article that came out last year about how the 340B is gamed by the hospital system, where they're basically expanding in the richer neighborhoods, pulling resources out of poor hospitals. Bill and I got a call from a reporter, and he was doing a lot of investigative work in Virginia, looking at this issue. And he used our database and he confirmed some of the things that he was finding independently. So that helped us be more confident about what we're seeing in our database and for people to use it. So with that said, Caitlin, any questions on the Q&A so far?
Yep, we've had 2 questions come in so far. We have a question from Chris. He says, assuming pharma is well aware of these practices, how have they responded?
Bill?
I'm going to turn that one back to you.
So we've reached out to pharma, frankly, the trade organization. We have not heard back. I don't know what they're doing with this database. Individual pharma companies, we've been in contact with them, and they are well aware of this information, and they've asked us to come and do briefings for them individually. So individual pharma companies are absolutely looking at this data. Pharma as a trade organization, I have no idea, because they've refused to talk to us. That's all? All right.
And I've been around a long time, and just a final editorial comment. This is the most screwed up federal program I've ever seen. It is hands down the most screwed up federal. I mean,
Yeah, I have a question. I'm Thomas Johnson, and I'm the executive director of ASAP 340B. And we're actually a coalition that came together officially in March, led by pharma and the community health centers. You are speaking the gospel with a lot of the data that you presented and a lot of the recommendations that I've read. And I'm actually hopeful that maybe you can do a briefing with our coalition at some point. Can you elaborate on the point you made about, and I hate to be partisan about this as well, but one of the things that we've been doing is reaching out to a number of caucuses, Congressional Black Caucus, Congressional Hispanic Caucus. I think there is general receptivity when our messaging is right. Can you just kind of speak to what messages you think should be stressed? And the other question I would have is, since Medicare Part B also is a part of this program, how would you make a pitch to the employer community about why they should care about the 340B?
So let me take the employer one, and then we can talk, both of us can talk. So employer community should be really concerned about this, because they're paying for medicines. And it's been shown, Adam Fine has done some work, great work in this space, about how there's overpayment because of the 340B program. So I know there's some employer folks that have called into this because they reached out to me when they found out about our tool. They're interested in learning more, but I think they're being taken advantage of, because what they're doing is buying low, selling high to them. And not only they're not getting the discounts, but they're overpaying for it. And it's impacting us. So the employers are definitely somebody that needs to be more educated about this topic. And as the program grows, they're going to be exploited more and more. So I think but I think they're in the educational phase right now. We even understand what's going on. With regards to location, it's to me, it's all about location. Look, I worked for a covered entity hospital as a resident and a fellow. I worked in South LA as an intern. I know those communities are in desperate need of help. This is a program that does help those institutions and those communities. The problem is, you can't tell me why those pharmacies are not in South LA, but in Beverly Hills or in Westwood or something like that. Doesn't make sense. That's not where the patients are. Those patients are not going to be able to travel, 10 miles, 15 miles radius to get to a 340B pharmacy. And in addition, if the excuse is that it's a mail order pharmacy, well, let me tell you something. There's a lot of pharmacies that can exist within that community to help that institution. And what bothers me most even is that they're out of state. Keep the money within the state. That's what is really the difficulty for me to get my head wrapped around about how we've let this thing get so out of control, is that not only we're not keeping the money in the community, we're not even keeping the money in the state a lot of times. And so I would say that's, to me, the worst part about this program, that it's not really helping the people who are intended to be helped.
Yeah, and despite all the egregious data we've shown, the political reality is that typically nonprofit hospitals in particular are the largest employer in every congressional district. That's just the reality. In fact, my own son worked for a Republican congressman. He was a legislative director. And I went to him with my paper and said, you know about this program? It's out of control. He's like, you know how many thousands of employees we have from the Cleveland Clinic in our district? Forget it, forget it. So that's the political reality, and that's a bipartisan reality because everybody pays attention to the largest employers in their district. However, I think with our tool, you could go to individual members and say, you know what? You're really being underserved by this program. There are not enough covered entities. There are not enough pharmacies. There are not enough clinics in your district compared to across town in this wealthy suburb. So I would think that would be the most effective way, particularly to get to members who may be underserved.
Bill, I get the Joel White, Council for Affordable Health Coverage. Thanks for doing this. I get the transparency desire and I understand the political challenges with getting Congress to do something. It just seems so unsatisfying, right? So have you ever thought about maybe just directing HRSA to issue program rules to protect program integrity?
Yeah.
You know, thinking about fraud, members of Congress are very concerned about fraud. They love talking about how they're.
I think that's a good strategy. I think what would happen though is you'd get litigation by the covered entities and they'd say HRSA doesn't have authority to do this, which is what happened with the definition of a patient.
I guess what I'm saying is Congress passes a law to
Yeah.
direct HRSA to do it
Yeah.
with the intent of program integrity and benefiting poor people. Right, so make it specific as to what they must issue around the regulations.
Yeah, no, again, I would start with transparency and then I would go there. I would say, okay, through transparency, we're going to discover where the real abuses are, where problems are, and then we can legislate on HRSA.
The other thing is that, Joel, you can put the cap back on a number of pharmacy is the problem here, because it's one thing to say that covered is getting it directly, the discounted drugs, but it's another thing that to see the top 12 pharmacies with contracts are all for profit, PBM owned, especially. Problem.
The other issue we've been exploring is, charitable care broadly, tax exempt status, and 340B in particular. There's no threshold for dollar amount or otherwise to provide charitable care. Saying if you don't meet a threshold for charitable care, then you can't participate in programs that are designed for charitable care, like 340B.
That's right. That's a very good.
That's probably a little harder.
It is harder than putting a cap on number of pharmacies.
So this last slide is a little obsolete. The link to our website, web tool, is now on the pioneerinstitute.org website. It's prominently featured at the top now, and anybody can go in and play around. And we would just encourage people here or people on the phone, if you have ideas on how we could expand this tool and put other valuable data on it, we're happy to consider those. Our intention is to continue updating it every year with new data as it exists now, but we'd like ideas on, oh, well, look at this aspect of the 340B program and publish that data. We're happy to get ideas like that. We'd enjoy getting them.
Well, this is probably something I could do if I went into it, but one thing that would be interesting is you talked about the dramatic growth of the program. And then you also clearly indicated there are some good actors and bad actors. Are the old ones okay? And as new health systems got loaded in as covered entities, did they get more and more worse? Or
Not necessarily. It's a mishmash.
okay,
It really depends on what institution. It's an institution by institution, state by state issue.
okay.
It's not, there's no uniformity to like the old actors are better than the new ones, or because some of these institutions, that have been around for a long time and that probably originally were qualified to be at 340B institutions are the ones that are abusing it the most.
Yeah, so for example, I'll call out a good actor, Boston Medical Center, which is in a tough neighborhood in Boston, right in the center of the city, has consistently given 7 to 10% of their revenues into charity care. And yet other hospitals will go unnamed that have huge endowments that are very wealthy are giving less than 1%. And that data is real.
I thought what Dr. Polia mentioned, mail order pharmacy better well. So I'm not an expert in commercial real estate. Who would put a mail order pharmacy in
But they
the
do.
most expensive residential zip codes? That does not seem a cost-effective business
But
model
they do.
anyway.
If you look at the data, it's very clear. They go to where the neighborhood, that's where the money is.
Yeah, and they want to bring in wealthy patients that have good insurance and they want a pharmacy nearby for those patients to fill their script.
Well, Grace Marie Turner, Galen Institute, thank you so much for doing this. I mean, so many of us who have been talking about the abuses of 340B for the longest time, having the data is really just invaluable and being able to, as you say, drill down to where the abuses really are. But back to the question about how to talk about this, I think that the voices of those entities, I'm thinking of community health centers, for example, that are most harmed by having all these, top $1,000 an hour lawyers that have figured out how to take advantage of this program for wealthy people in Malibu. And I really singled them out because everybody knows everybody in Malibu lives in $1 million or more house. That is not the intent of this program. But the voices of those who are being harmed are not loud enough.
That's right.
I think that's really where we need to be able to say, for example, in South Central LA, where there isn't a pharmacy within 15 miles,
Right.
they don't have access to the program that's designed for them.
For them, exactly.
Where in Malibu, they're just raking it in because they figured out how to take advantage of this very flawed piece of legislation. I think that's also an important point.
Yeah.
This was poorly written and lawyers out there were trying to figure out how to take advantage of it for rich people.
Right.
And it's the poor people who was designed for who are being harmed. We need to hear those voices.
What's also interesting, I remember hearing, I want to say, I think it was back in April, where they were discussing the program, and the transparency issue came up, and Bashan's bill, I think, was being discussed, and it was a response from the hospital community, and one of the Democratic members of Congress basically saying, with regards to transparency, this is a regulatory burden for us. And I am thinking to myself, hospitals, systems have enormous resources. And you're telling me that you can't adhere to the same principles that these clinics were much smaller staffed can adhere to? I mean, I find that incredibly hard.
I practiced in a hospital for many years. There's a thing called JCO. They have to report almost everything, including the toothpick that they, so it's not an enormous burden on them. It's just that if they don't have to, why would they? And I think going back to Grace Marie's comment, I think the employer community needs to really wake up here. They're being, their insurance premiums are going up and they're paying more for it. So with that said, we're about 5 minutes. Any more questions?
A few more questions
Oh.
from the chat. Someone has asked if you are familiar with the NASHP hospital cost rule. They suggest that might be an opportunity.
National Association, I'm not, but I'm sure we can look at that.
And another question, someone from the audience would be interested to see what contract pharmacies are charging covered entities.
Very good point. That's another one that we can't find the numbers because,
It's all very opaque.
very opaque, especially with the contracting models that we currently have in the pharmaceutical space.
The final question, in states where 340B legislation is underway, would you consider doing legislative briefings
Absolutely.
for groups in those states?
Yeah, of course.
Of course. We're here to help out and have an open discussion and dialogue. So, thank you, Caitlin. Thank you, Bill. Thank you, everyone.
Thank you all.
Thank you, everyone, for joining.